Yes, enchanted, my friends, and welcome to the I Give a Damn podcast, made possible by Fluorescene Media, the same company behind ODs on Facebook. My guest today is none other than Dr. Amanda Legge. Amanda is not only an expert in age-related macular degeneration, but also in what I would call patient interaction and rapport, where getting to know her patients on an authentic level has not only improved her overall patient numbers and business growth, but has accessed the opportunity to leverage patient education and therefore improve patient outcomes. We also discuss optometry's heightened role in management of macular degeneration, including her experience with dark adoptometry, as well as nutraceuticals and lifestyle changes and how it impacts our retinal health. We also touch on her experience with what I consider to be a young optometrist's dream, where she not only got to be an extern as a student in an eye clinic, but then hired on by that clinic as an associate and eventually asked to become partner in that same clinic. I think Dr. Legge has a lot to teach us, as well as just being an amazing person to speak with. So please hit that subscribe and follow buttons. And here we go with Dr. Amanda Legge. Well, welcome to the podcast, Dr. Legge. Amanda, what was your last name? Like your maiden name?
My maiden name was Gryskevich, which was Gryskewicz.
Wow.
So I cut it in half.
I imagine how many, were you practicing with that name before?
No,
or?
so we got married in between like college and optometry school.
Okay.
So I simplified it. I know a lot of female optometrists that got into the business and then didn't know what to do with their name. So I simplified my life.
I know I've ran into the fact that my last name is Allen, and some people confuse my last name and being that it also can be a first name. So I get that confusion a lot, but I can't imagine how patients would be like, Dr. G.
My mom was a teacher and she went by Mrs. G.
There we go.
So that would have been it.
Now, Amanda, you have a really kind of a cool story, that I think a lot of, especially younger doctors, maybe you in a way you've kind of lived a dream in that you went from being an intern as an optometry student, right?
Yep.
As an extern intern, and eventually got hired on, and now you co-own it, right? You're a partner within the practice?
Right.
So can you give us, just for our viewers, our listeners, your background, how that became to be?
So I think some of it was by design and some of it was just serendipitous, where the design part of it was I knew where I wanted to practice because I didn't want to go too far from family. So instead of choosing externship sites at, all these cool exotic locations, I decided to make a network around where I wanted to be.
Oh, smart.
So a little strategic that way. And I knew that because I wanted to practice within each area, I better be at my best game because I want at least recommendations from these people, as my baseline for things. And if something better happens, that's great. So that was the design aspect of it. And then, the serendipitous part about it is just finding this practice through the internship site. And they made us go and interview in person because they're not too far from the school. So
before you even got to be an extern, you had to go interview to be an extern. Okay, I haven't heard of that. So.
Yeah, so that was it was a lot of Dr. Corbin, is the main owner of the practice for many years now, and that was his requirement for it. Now he does it by Zoom instead because we're BC or after BC with COVID. But I thought that was really good because I got to know his personality a little bit, what the flow of the clinic was, and it's like, okay, this seems like a really good place. So I think it's hard for students to even know what internship sites to choose. They're just, this is your list. This is who I participate with, and good luck. We had the option to read previous interns, reviews, we'll say, of the practices, which helped a little bit, but everybody has different personalities, so it doesn't always match. People write negative things about awesome practices and awesome things about easy practices.
Right. It depends on what the student's expecting and what they really want out of it too.
Correct. So it's hard to choose that. So that's, I think, where the serendipitous part came in, that I was fortunate to find a practice that matched my style and my personality, and really allowed me to flourish with that part of it.
What would you say is kind of your style? If just for, again, our viewers, listeners, where are you practicing? And kind of tell us about your practice and your mode of practice.
Yeah, so I practice at Wyoming Optometric Center, which is near Reading, Pennsylvania. I've been there working now officially for 10 years, but I've been there, I guess, 12 years with the intern. And what drives me is just having education with patients. I love taking the time and getting to know who they are, what their occupation is, because I will check people's like low light vision for reading glasses, say if they're like a waitress or something else, because they probably don't have the best light in their bifocals as they're doing things. So you think about this stuff and you get to know people, and I love asking questions of people and just learning about various jobs that I didn't even know existed. And the practice is set up very, I don't want to say casual, but it's very just friendly and get to know each other, take the time to educate people. We have a lot of the new technology, so really helps the way that I talk to patients and practice because of that too.
And I think it's really smart that you bring that up, that like what your patient's life is like, because I think in school we're so drilled into our head, like the proper testing distance, the proper lighting, all of the ideal testing world, like especially if you're doing a research study or something like that. But that's just not how people use their eyesight, their vision. And I'm going to have to think about incorporating, being a little bit more.
I love asking interns that when they come out and they're, reporting about whatever refraction they have. I'm like, oh, so what do they do? Most of them say, oh, I don't know. Until they pick it up over time, over the months that they're there. But I'm like, it's important because of A, B, and C, depending on their needs.
And not just, we're so focused on treating the eyes, the vision system. One thing that I've learned over time is that if I spend more time asking my patient about themselves, about what they do, about what they care about, what their passions are. I like to go beyond just like, what do you do for a living? I like to be like, so what do you like to do? What are your passions? Like, what are you looking forward to? What do you do with your children? Like, what do you, getting to know them on that level, I have a better bond with them. And I honestly think they're more like, they don't just see me as a value because of my work, of my expertise, but they want to come see Dr. Allen again. They look forward to spending time.
Perception is everything, right?
Right.
And being genuine, people understand that. You can't fake that kind of personality.
And I think it's a little challenging because the way our education, I think with all medicine, there's a challenge because we are trained to think about the disease. We're trained to think about the eyeball, not necessarily the person.
Yeah, and that was a big, I'm going to say learning curve, I think, as becoming a doctor, was the emotional aspect of all of that, where we learn what disease is, we learn how to manage it, we learn what to do about it. I didn't have one course about how to handle the emotional aspect of patients. Tell somebody they have macular degeneration for the first time and you can see their eyes just glaze over, and I can give the best education of my life and get an Oscar for it. But I know that they stop listening to me because they're thinking, oh my gosh, I know so-and-so, they're getting injections into the eye, I'm going to lose my vision totally. And so having that personal rapport with somebody is so important to walk them through the process that you are about to begin your journey on together.
And that's definitely something that I've carried forward too. When I was at the VA, I remember I did a low vision exam with a guy where we spent most of the time him just crying and telling me his like PTSD war stories. And I mean, this particular gentleman had vision loss, severe vision loss for many years at this point. And if anything, he almost just needed a therapist or a friend. And that I got to be there for him. But that's a memory I'll just never forget. And
optometrists, I always say we're the primary care doctors, right, in the eye care world. And you go to your same primary care doctor probably for many years. Many of us stick with the same one for a long time, and you get a rapport with them. And optometry is even more interesting because most of us practice cradle to grave, right?
Right.
So you see husbands, you see wives, you see grandparents and parents and kids, and sometimes you have 4 generations that you're able to follow, and you know all these people by name. So one day, the wife comes in and says, my husband passed away. And it's sad for you, it's sad for them. But again, that bond is just so intimate and important and trustworthy in your doctor.
Yeah. I think some of the experiences I've had is you get to, especially if you're at a clinic a few years, at least probably 3 to 5, then you start to see return patients, and you start to know them a little bit more. You remember their family names. I've had like I knew a family, and eventually like the mom came in one day and I could tell something was off. I could tell she was emotional, or she wasn't the same. And I'm like, "Are you okay? Like, what's going on?" I don't mean to pry, but then she ended up kind of breaking down that they were having marital issues, and she confided that with me. And again, ultimately it's just amazing, those relationships that you do build. Now, with your practice, you're more of a medically based practice. It sounds like you guys have a lot of different technology, like you mentioned. Are you doing? Do you have a subspecialty? Do you have a focus? So
we all kind of have a focus, which is nice. We're an all optometry practice. We all do primary care, but we have like our own niche sort of specialty or just interest. So somebody does dry eye. We have scleral contact lens fitters. Somebody, like glaucoma, we do keratoconus management and such now too. And then I do most of the retina work.
Nice. And that's honestly kind of like how our clinic runs as well.
It's a good inter-office referral.
Yeah, you're right. You're just constantly...
it's okay to not know everything. It's okay. Like I would love to get more OD to OD referrals.
I think
it's okay to not know everything.
That is a challenge, I think, in our entire profession, right? I think some practices, or it just seems like that isn't as happening as frequent. And I understand, like, we're worried you're going to lose that patient if you also happen to sell glasses and contacts, that sort of thing. But I think it's also just showing some level of respect at the same time. But with being more on the retina side of things, I know you write frequently. You have something published. I mean, how long have you been doing that, and what really got you even interested and keep going in publishing articles and writing?
So I think, again, it was design and serendipity at the same time. Where I went to Salus University. I graduated in 2012, and through my third and then beginning fourth year thinking about residency, I was just sort of tapped out with school, like mentally. I was like, residency it's just not for me. And what Salus did offer, though, were advanced studies programs at that point. So they had various options. I chose retina for two reasons. One, I always thought it was just fascinating with all the stuff we can see in the back of the eye and systemically, neurologically. But two, it was also kind of my area that I was least confident in. And I think a lot of us are, because you have to have the really good techniques to get the visuals that you need in the first place.
Like, especially in the peripheral retina.
Yeah. And then you have to be a good diagnostician, because so many things overlap, so many things look the same. And there's a true art form to the education aspect of it, especially when people come in, perfect 20/20 vision, and you're finding an issue that they weren't expecting, which is sort of a weird eye care phenomenon.
It is. I always try to tell them, like, you don't have pain receptors in the back of the eye. Like, you're not going to feel pain. If you did, you would be screaming on the floor. So that is a really, I love how you noticed that was a weakness of yours. It's almost scary, because I think in anterior segment, that's how I felt in going into residency. I was like, I remember AntSeg classes. I did well in those classes, but when I saw a cornea with edema and there's something going on, there's a uveitis of some kind, I locked up. I was like, there's so many variables. And thankfully, in my residency experience, I got some push in that direction. And I was forced to start reading articles a lot more, and I had better understanding for it. And even more so after residency, just seeing more volume of everything that comes in off the street. And now it's like what I kind of love. Yeah. As much as I love and respect retina as well, I think there's absolutely a beauty with retina, of diabetes.
I agree. When I did the advanced studies program, one of my favorite professors there, he's like, well, why aren't you doing AntSeg? Because there's nothing in the retina that we can treat. So he's like, you're just doing retina because it's intellectually sexy. I was like, maybe.
That's
but also,
good.
I love that. I'm taking that to the grave.
Yeah, you might have to make a shirt that says that. I'm sure there's a, like, the Retina Society would love something like that.
Yeah, exactly.
Hey, I just want to take a quick pause and give a shout out to Fluorescene Media. Not only do they make this podcast possible, but they are the company behind the social media community ODs on Facebook, which is the longest running optometric community with the most active discussions amongst over 46,000 eye care professionals. So, if you're not already a member, don't miss out and join the discussion over on ODs on Facebook. Otherwise, let's get back to it.
But I said, we don't have to treat things, but there's a lot of stuff that we can manage with the retina. Mm-hmm. And macular degeneration, dry macular degeneration is one of those areas that I feel very strongly that optometry should own that, like we have owned dry eye disease. You know, we don't refer to ophthalmology anymore for dry eye. You're seeking out a dry eye expert, which are generally optometrists. And I really think that's where dry macular degeneration should be, because maybe we're not treating it, but we are managing it very well to hopefully that they never have vision loss, or if they do, like we are on top of it, they are educated, they know what to do, and then we can get the retina specialist as soon as possible. And you know what's great about that is my retina specialists love me, because you send them patients with good vision when they just convert to wet, and they look like a hero.
That's true.
You know what's not fun about being a retina specialist is injecting people's eyes over and over again to stabilize vision and not really make it significantly better, especially the ones that are caught very late. So I think it's honestly, at this point, hopefully macular degeneration will change in the future. But at this point, retina specialist job is not that fun because it's neurotissue, right? So the surgeries that they can do, repairing macula holes and removing epiretinal membranes, like such delicate, amazing procedures. But to the patient, they just went through this huge situation that they're mostly scared of. People are terrified about their eyes, and they don't have perfect vision afterwards. And to us, it's a great outcome. We're like, this is amazing. Like, this is what this paper said.
Yeah, you went from 2080 or 2100 back to like 2040.
Yeah,
you know,
but
with
they're not
metamorphopsia.
Happy because exactly, because their quality of life is still dramatically affected once they walk out of your office.
And they mentally think the surgeon messed up, and it's like, no,
this is an amazing outcome. He did an amazing job, but it's just the quality of life that is different, and it's hard to mentally grasp with.
And it's interesting because you mentioned how like dry AMD is something that we really should own, and I know we manage it. We buy close follow up, maybe AREDs depending on the stage, and then now at least with the advent of some geographic atrophy treatments, that helps us kind of early. Okay, we can get them hopefully same thing to the retina specialist so they can maybe get that injection. But what I'm interested to hear your protocol, because not only are you passionate about knowing, just practicing, but also educating your patients. I'm curious as like, how do you like to talk to your patient? If I was your patient and you were just diagnosing me with early dry AMD signs, like what would you explain?
So I'll tell you how I make my job easier too.
There
all
you
right.
go.
So say you're a new patient. All right. I don't know you. You come in and I find drusen. Unless it's very obvious or super advanced, I never tell somebody that visit that they have macular degeneration. But I say, I have findings that are concerning. Usually take a picture. A picture is worth 1,000 words, right? And you can physically show them what you are visibly seeing in the retina and why you're concerned. I'm a huge fan of dark adaptation because it's 90% sensitive and specific for macular degeneration if they're in that age group, and you rule out, inherited retina disease in that first. So
can I ask first,
go.
with so you guys are probably using the Adapt DX?
We are.
With that, are you screening for patients before the exam? Are you, once you identify it, you're like, okay, we need to have you back to do this test? Like, how are you?
At this point, we're doing it when we identify any drusen at all. Okay. So one pinpoint, like teeny tiny drusen, like anything that
within
you find
the macula, or even if you saw one a little bit outside?
Peripheral. So it's really well covered for any kind of drusen. But the fact that I have a 90% accurate diagnosis of macular degeneration to tell them when they come back for their follow-up, and I do their OCT and I do their dark adaptation, and I can tell them with 90% confidence, you do or do not right now have macular degeneration. And we don't get to do that because it's, while there's, scientific measurements and how the ARED study graded macular degeneration, most of us grade it by feel, right? Like there are standards, like you only need one large size drusen to be intermediate AMD. But most of us don't think about that. And you're like, oh, there's just one drusen. No big deal.
Right. Or then there's pigment changes like that.
Correct.
That is a whole compounding factor of that too.
Yeah, but most of us diagnose by feel. And then you're left with giving patients some ambiguity that there's some age-related changes. I'm sort of concerned about it, but
through a cloudy cataract view and all that.
And because there's not a lot to do about it, what do we say about it? You know, I think going back, we talked about The Office earlier because I'm from like up Scranton. I love when there's a quote from Michael Scott. He's like, well, if I was your doctor, like I wouldn't tell you if you had cancer, right? What bad news.
What bad news, yeah.
And it is bad news. And that's why I go back to the emotional aspect of patient care, because you come across a lot of that when you're talking about a visually potentially debilitating condition often.
Right. We want patients to like us. I think that's the hard line between being a doctor and a friend, and sometimes a business owner, right?
Agreed.
You want people to like you, you want people to come back. How you can't help a patient if they don't come back,
Right.
But at the same time, they need to know what's going on and to properly educate them.
Yeah. So because it's such a huge conversation, and I'll go through that conversation with you, I show them the drusen in the day of their new patient appointment, bring them back for the OCT, dark adaptation, and just what I term an AMD consult. So now we're allowed to bill by time per the Medicare guidelines. So I take advantage of that I don't use a slit lamp. I don't do anything except review their new studies that we just did and have the full-on conversation top to bottom about macular degeneration.
It takes a long time too. There's so much.
There's so much. So I give myself that time and grant myself that gift because I cannot do that conversation several times a day on the fly.
Right.
Not to do it
I
justice.
applaud that. Unless you want to make YouTube videos of you doing that explanation.
Yes, I can just show it all the time.
And then just
Oh,
have
I like
that in
that.
a reel, I'm curious because of the drusen. Now, you talk to different professionals. We know from the results of the AREDS 1 and AREDS 2 studies, we know what the standard, okay, once they hit intermediate, then we can start prescribing AREDS 2 vitamins to patients. But I know a lot of doctors will feel that, hey, even if you have one single drusen, you're not quite intermediate, it's enough to be concerned. They at least discuss the option if they want to take, whether it be AREDS 2 or some other form of supplement, vision supplement, because there's 30 brands out there.
Right.
What are your thoughts, feelings, rationales for that?
So I think we need to take a step back from AREDS and look at the forest through the trees because AREDS was designed in 1990. You know, the original concept. And AREDS 2 didn't change the formula much except for replacing beta carotene, which we knew was causing increased incidence of lung cancer. So we had to change it. We didn't really have a choice, is how, you know, AREDS 2 partially came to be. And the other part was in 1990 when it was designed, lutein wasn't commercially available. They couldn't use it.
See,
so they had to use some carotenoid similar, which was beta carotene. But beta carotene is not found in the retina. So it was close and
That's
did
true.
sort of the same thing, but not exactly the same thing. So what I love to take a step back from AREDS and really think about it is what AREDS gifted to us was understanding how nutrition affects our whole health, our whole body health, starting with the eye.
Yeah.
Because what other professional, MD, DO professionals for standard of care recommend a nutraceutical?
I think there's some, you know, with pregnant women, there's folic acid they have to be concerned about. Vitamin D is now a little bit more focusing, unless
But if
they're
you're like treating a
unless
disease
they're
process.
unless they're running a panel, a vitamin panel, they're not prescribing multivitamins. If anything, most will say no, it's multivitamins or vitamins is a BS industry.
Yeah.
So
Yeah, so
I
there's a lot
always
of back
raise
and
my
forth.
hand about that when I hear other doctors saying like, don't take vitamins. I'm like, unless,
Yeah.
you know, like,
Yeah. And if you take a
that's
step
what
back
you
from it and really compare like AREDS 1 and AREDS 2, the cool thing about it is that AREDS 2 worked better than AREDS 1. So it wasn't just less lung cancer and we did a swap.
by like 5%.
It works a little bit better. And as they compared, you know, groups who had high intake dietary lutein compared to low dietary lutein, it was like a 26% difference, that those with the low intake were more likely to have worse forms of macular degeneration. So if you get into some of the full scope of AREDS, it's really telling us that nutraceuticals, specifically antioxidants, ACE zinc, CE zinc, copper to offset it, are antioxidants. and the carotenoids, whether it was beta carotene first or lutein and zeaxanthin. So if you take a step back further, in the general American diet, even though we don't have a healthy diet, and we can talk about that, a whole other conversation. But even though we don't have,
that's a passion of mine. I love thinking about it or discussing it. So.
Yeah, because even if we Americans don't have a healthy diet, what we get generally, and we're not nutrient deficient is C, E, and zinc. Like we get that very generally from our diet, and most people in America are not deficient in those things.
Sure.
You know, unless you're elderly, have poor absorption, maybe after bariatric surgery to pay attention to a little bit, but general population wise, that's not the concern. But what we definitely don't get enough of, right, is the lutein, the zeaxanthin, that we just consume so little plants, fruits and vegetables, that it's not good. So I'm in one of the camps that I do believe in lutein and supplementation early, because I think, at least as of 2023, AMD is a preventative medicine disease. You can't reverse it. But if we find it early and talk about, you know, even if you don't do nutraceuticals, just the education part of it, that, you know, you can slow it down by lifestyle changes. And I tell people, like, not joining a gym. I'm like, I'm asking you to walk and have movement during your day. Like, don't sit on the couch all day. Find a hobby. Find something to do that keeps you energized. Diet is really important. And while, you know, the Mediterranean diet has over and over again shown to help reduce risk of AMD, reduce risk of dementia, reduce risk of cognitive decline, diabetes, that it also is just, if you eat less processed foods and more stuff direct from Mother Nature, is exactly how I explain my diet. I'm like, I don't subscribe to a specific one. If you want, my best recommendation is Mediterranean.
Yeah, the best thing is what works for you.
Yeah.
But it's like, if you're looking at a purely nutritional, or what's been published in the research as being less risk for all these different conditions, it's like sticking to something more on those guidelines.
Yeah, because you're not going to give a nutraceutical and magically cure a McDonald's dinner every night. Like, it has to be both. And I have had people come back and they're like, you know, since you told me that, instead of eating chips at night, I've been getting peppers, and I'm, you know, cutting those up and slicing better. Like, they didn't change their whole diet, they didn't change their whole lifestyle, but they made a healthier choice because of the education I gave them. So I'm also not in the boat of like, oh, you're not following my recommendations, so that's just not okay.
You can't punish them.
Like, they're making steps and they're making healthier choices because I educated them about it. And that all comes back to AREDS, that if we didn't have those nutritional supplement studies, we wouldn't be talking about this so much. And I think where optometry and ophthalmology at this point are sort of diverging is that we're becoming more and more preventative care medicine.
Absolutely.
And they're becoming so much more surgically specialized as all these different techniques come out, that they're veering the opposite direction a little bit and treating much more allopathically.
Yeah, and certainly I think there's, if anyway, that teamwork between the two specialties, that's, I think there's a beauty in that.
Yeah, so important.
Because of how uniquely specialized a lot of ophthalmology is with those surgical techniques. I mean, there's a lot of skill, there's a lot of knowledge that's involved in that, and
to which I don't have the patience or the dexterity to do some of the amazing things that they do.
For me, I just don't have the stomach for it. I have steady hands. I can, when it comes to the cornea, I'm great. I can debride corneas and do all sorts of great stuff with it. But as soon as I see blood and something like that, even watching, if I sit in a retina lecture and they're showing any sort of procedure where there's a lot of blood coming in and out, I'd get wheezy, and I'm just like, I'd pass out in the OR. I would not be a great great surgeon.
And I much more prefer the in-office and talking back and forth and education aspect. Like, that just fits my personality more.
Right, especially with the patient connection. I think that's great. The idea of like supplementation, omega-3s, I think that whole idea that, especially now with, I kind of talked about this in a different interview, a different episode, about the new geographic atrophy injection and how that works on the complement system. It's like, wow, we have so much more knowledge of how inflammatory cascades play a role in advancement of macular degeneration. So I
think it's a hopeful time to have macular degeneration. It's never a good time, but it's a hopeful time for it. That there are ways that we can catch it very early and do this education or intervention and preserve good vision for a lifetime. There's ways that we can catch conversion to wet, so early now that patients are 20/25 or better at the time you start injections. And most of the studies show that whatever the visual acuity is, at the time they convert to wet is about what their visual acuity is 1 and 2 years after. So the importance of catching that as early as possible cannot be understated, which is why the education aspect of it is so important to know with your patients. Because I've had patients that look not that concerning to me who did convert, and other patients that I'm like just waiting any day for it to happen. And it's been, 6 years that you can't assume who's going to and who's not, because while there are statistics and analysis, I think macular degeneration is a very individualized disease and process.
Right, and I feel like in even reading into textbooks and research, it seems like there could be like little subcategories even amongst, like for us it's easy, dry, wet, or different stages of advanced, intermediate. But then you have polypoidal, and you've got all these other little things that are kind of mirror mimickers almost. With being that, again, communicating to your patients, I heard a story, and correct me if I'm wrong, but that you joined like an AMD support group online, and you just asked people like how did they first hear about AMD?
Yeah, so when I joined was October of last year, October of 21. So it's been a little over a year now. I joined and I asked very honestly, I introduced myself as an optometrist, and I said, what do you wish your eye doctor told you at the time that you were diagnosed, like that day? And the responses were really interesting. It wasn't necessarily the way that the doctor said it, it's the lack of information we give them. So there are some people that went to see a retina specialist, and I'm sure in the scheme of their day, dry AMD, early AMD is like, cool, like you're great. I'm going to go inject 50 more people behind you. So it's like, okay, you have macular degeneration. Here's a pamphlet. Most every retina specialist has them leave with some AREDS recommendation, right? No matter what the study says with intermediate, most of them do. And, the people on the Facebook group would say, my doctor handed me a pamphlet and I was devastated, and I sat in his waiting room and cried for an hour before I could drive myself home. Gosh. Or the one woman said, I wish that my doctor told me about stopping smoking, because I was going through a really hard time in my life, and I actually picked up smoking after I was diagnosed with macular degeneration, but I didn't know the association with it.
Whoa.
I wish that my doctor was honest with me, was over and over again. I wish they didn't say, oh, you just have some age-related changes. I wish they said it out loud and what it is and how we do about it. So it came down to they wanted education.
With what have you found success with providing this education? Like, do you think, do you guys have pamphlets? Do you, like you said, you sit down and you have full
I wrote a
discussion?
16-page booklet I hand to every one of my patients.
Whoa. Is it like loaded with studies?
It goes through, no, it goes through just front to back what I want to cover with them. So it goes through the difference of dry versus wet. It goes through how we differentiate early, intermediate, and severe. And I tell the people on that Facebook group, like, what you need to know about your macular degeneration is it wet or dry? Because some people don't even know.
Sure.
And it's easy for us to know, are you getting injections? No. Okay, you have the dry form. But patients don't know the difference between it. So you need to know if you have wet or dry. You need to know if you have it in one or both eyes and what stage that you are in. And that's a question that you should pointedly ask your doctor about. And then with follow-up visits, the appropriate question is, do you see any progression to follow it over time? So I will go through dry versus wet, all of the lifestyle changes. And I do have little blips with the studies in it. I don't have what's it called? Not a bibliography.
Just
references. I don't have references. Cited. Yeah, I don't have references in it, but it does go through the statistics and my favorite. This is my favorite explanation of macular degeneration, and I tell every single person about it. I tell them that macular degeneration is a disease process of the transport system between the healthy retina on top and the vasculature that supplies it underneath. Sure. And there's a membrane that's there, and it's really important because it helps with the transfer of nutrients in, waste products out, and making sure that toxic stuff doesn't cross over as much as possible. But in macular degeneration, that gets impaired, where what we first see are these yellow deposits that we call drusen. But what that means is, if you have macular degeneration, it's not just that spot here and that spot here that's dysfunctional. It's the entirety of the macula. And that's why dark adaptation works, because it's not isolated drusen that causes a delayed dark adaptation. It's the fact that there is this cholesterol and debris wash underneath the retina that is visualized in electron biomicroscopy, but we don't take people's eyes out and dissect them in our offices.
Right.
So we know that it's there scientifically, but we can't visualize it on our photos or OCT even yet. But what dark adaptation is really checking is that ability of you to transition from bright to dark, like going from a bright sunny day and walking into a movie theater. And when your mom said carrots were good for your eyes, she was right for this exact reason, because vitamin A is extremely important in that process. But vitamin A is also one of the larger molecules that has to push through our bloodstream and into that membrane. So while I see these drusen build up as waste accumulations not getting pushed out of the retina, what's more concerning is that that membrane is preventing nutrition from the bloodstream into the retina. So you have two options to potentially lose vision over time. Either you can stay in the dry form, which essentially is just the retina not getting the nutrition it needs. Of course, we know it's more complicated with that, with the inflammatory cascade, but it's not getting the nutrition it needs, and it just sort of dies off and it atrophies, and it's not able to continue living. And the second way you can lose vision much more rapidly, and that I'm concerned about in the short term, is converting to the wet kind. And that occurs when new blood vessels grow underneath the retina and try to push through. And while in theory, right, it sounds good because you're going to get a new pathway of nutrients, of oxygen to the retina, the problem with new blood vessels is it's not the same architecture. Yeah. So they just leak and they bleed and they cause bubbles in the retina, and that's what causes the distortion. And if we don't treat it with injections, it is only going to get worse.
I like to mention to my patients how if they could picture weeds or like tree roots invading into the foundation of their home, like it ultimately just destroys the architecture of how the retina functions, and you're not going to see.
Yeah.
And so that's some people, just that visualization of seeing something grow in, it's like that's what's happening.
Agreed. And no matter what we're treating with, whether it's AREDS, whether it's another nutraceutical, whether it's anti-VEGF, whether it's the new GA drug that's out, all of it is just meant to slow it down. None of it's curable. None of it's completely reversible. I've found if you catch the wet conversion early, that the injections are not a life sentence, that I have had patients discontinue, and we watch them very carefully. But that's why I truly believe that macular degeneration in the year of 2023 is a disease of prevention in the first place.
Do you recommend, let's say you just have family members of somebody with AMD, and maybe you're not seeing drusen or anything like that. Do you recommend these lifestyle changes to every patient? Do you recommend eating fish versus omega-3s? Do you
we're moving in that direction. So we're about to invest in a carotenoid scanner, which I'm excited about.
The transdermal one, or through the MPOD measurements?
So I think that is going to open an entire other avenue of conversation of wellness to our patients. Because especially at first, if they're not on nutraceuticals or they choose to manage or change their dietary lifestyle, whether AMD, diabetic retinopathy, whatever, that first snapshot of what your carotenoid levels are, it's indirectly telling you about the whole health of your body. Because if you're not consuming enough plants, fruits and vegetables, you're not getting the nutrition that your entire body needs to really, sustain itself for the long term. So it's a really good indicator of that. Once you start supplementing with carotenoids, it throws that off a little bit because you're only supplementing the carotenoids that come up. But that first snapshot and then discussion of, I can tell how you're eating, and I can tell that it's not the best.
Right.
And by the way, did you know that healthy eating reduces your risk of macular degeneration? It reduces your risk of cognitive decline. It reduces your risk of dementia. And those are huge factors that most people aren't aware of.
And I think the big challenge is there's a huge, and part of it's our medical infrastructure is rotten, and our culture, especially here in the United States, I think is also very off the rails, especially in terms of diet.
Yeah.
People, you'll tell them that. You're like, wow, your scores are really low. And they're like, but I eat healthy. I eat Brussels sprouts covered in butter once a week. To anybody, like, that's, people think just because they eat peas, they're green, that's healthy. And it's like, that's not, like the Mediterranean diet you mentioned. People eat a meat lover's pizza, a whole meat lover's pizza from like Domino's or something. And they'll say, well, that's that's Italian. That's a Mediterranean diet.
Yes, yeah.
Yeah, really.
But life is a marathon, right? It's not the short-term decisions you make. It's the patterns of behavior you have over a lifetime. So you either have that drive to make it happen or you don't. And again, I don't judge people for not doing that if they don't want to. I am there to help them and be their doctor and tell them the hard news, but always try to keep it hopeful.
Right. And also just be looking at the science and discussing that with them. It's like, look, I'm not here to make a judgment on you. I'm just here to tell you what my findings are, how I can help you, and this is what the science says.
Yep, exactly. So with continuing with that booklet, so I'll go through and like highlight exactly what's pertinent to them. You know, the lifestyle changes for everybody. The if they're dry or wet, exactly what stage I'm putting them in. It goes through the various tests and why we use them, from photography to what autofluorescence does, how it works, OCT, dark adaptation, why it works. It talks about the various treatment options. So, you know, anti-VEGF, and then I have to add now for some of the GA drugs.
Yeah,
and
you have to update
I have to update it, I know, which is a good thing. And then I do have a whole section just talking about nutraceuticals, because if you've ever just wandered through a pharmacy to the eye vitamin aisle, like, you'll drown.
Yeah, there's at least 12 brands just at any local pharmacy. And then you go
Right.
online and there's 3 million of them.
Right. And you don't know what's in them. And some people are aware of, most are not aware that the supplement industry is not FDA regulated,
Yeah.
which means, you know, they can advertise whatever they want, but it doesn't mean that it's absorbed into your systemic system appropriately. It doesn't mean it reaches the retina appropriately. So I do have a whole page explaining why I want them to take a recommended name brand supplement, whatever that may be, because I think there are many good brands out there. But having them on a specific recommendation avoids them spending money that may not do anything, right? Sure. If you're going to make this investment, make a good investment, and what I know is going to work on a scientific basis, and avoids the confusion and the discount shopping that you can get the very, very inexpensive vitamins at Sam's Club or what have you, which sounds great for the price, but why are you putting something in your body if I can't tell you that it's definitely doing what it's advertised to do? So I do go kind of deep into that with the handout as well. And then it talks about, I'm a big fan of the 4C home device.
Sure.
Again, catching wet very early. Patients like it a lot because the Amsler grid is only so good.
And that describe that a little bit better for of how that works and how you guys utilize it.
So it's a home monitoring system for conversion to wet macular degeneration. So it's not something that we utilize in the office. It's something that we write like a prescription for, and then Notal Vision does all of the rest in the background stuff. So they will authorize insurance. Most with Medicare and a supplement pay nothing per month for. It is approved by insurance. Others have a copay, which ranges from $20 to maybe $70 a month, depending, or if you're commercial insurance that they don't cover it. But it tests each eye individually at home for the presence of metamorphopsia, and it communicates with me if there's a change. So if it's detecting a change in metamorphopsia, I will get an email, I get a phone call, I get a fax. Like, they make sure that you know. So then I reach out to the patient and have them come in for, an emergency type visit, and we'll check. And it checks for metamorphopsia, right? So you have to use your brain a little bit, because I've had one change because it was their geographic atrophy enlarged a little bit, which did change their metamorphopsia. And I had one, his epiretinal membrane changed a little bit, which again, so then I communicate.
Nothing like dry eye or...
I haven't seen it for that yet.
No anterior segment.
I haven't seen it for that yet, because it's not... It doesn't alert me from one abnormal value. I'll say it does a cluster of them, and if it knows it's a true change, it will tell me. So maybe dry eye might affect it on the short term, but it's not enough for an alert, I'll say, that I have seen.
So that's great. I think I've heard of it, I've known of it, I've never had a chance to utilize that myself, but I can see that. Wow, that has and if it is that accessible, it's like, wow, that actually has a pretty good role. So that's pretty cool that you guys have that as an option.
A role in their own healthcare, right? Because I'm only a team member with them. I can't do everything for them. I can't cook them dinner, make them take their supplements or what have you every night. But I can be a team member, and I can be their cheerleader, and I can help them in the right direction.
I really love that attitude around it, and I try to encourage that same sort of thing. I want to help my patients become an advocate for their own health, right? And a big part of that, going back to education. Now, before we kind of wrap this up, I just, out of my own curiosity, because you kind of mentioned you guys are looking into the transdermal carotenoid measurements. What is your opinion on macular pigment optical density MPOD measurements? Have you had experience with any of that? What are your thoughts?
Not in my own office, but I think just scientifically, MPOD is still a subjective test, so you'll get some variability. Whereas the transdermal one is truly objective and is a little bit more reliable. Your skin cells also change every 30 days, so it's a cool way to monitor it over time and actually see if the supplements are working or if they choose dietary habits. How is your diet this time? Even, diabetics that you're not recommending carotenoids for, and you talk to them about nutrition, you can utilize it for that. I mean, like, oh, you had a really good, 3-6 months, whatever it was. Like, good for you. Keep it up.
Diabetes is even more in the world of nutrition, and I think unfortunately there's a lot of gurus and confusion out there, but that's what I think is the true beauty.
Well, I'll tell you a story about nutrition that opened my eyes. So my dad, a few years ago, went to his primary care doctor, and he calls me and he's like, hey, so I'm borderline for hypertension, and my sugars are kind of borderline. So the doctor gave me 3 months. I'm going to get my diet in order, and we're going to recheck and then see if we have to start medicine. Okay. My dad is an intelligent guy. And so 3 months goes by, and he calls me and he's like, so my values are worse. I said, what? I'm like, well, what are you eating? He's like, well, I changed sodas to Gatorade, which is salt. And I changed
salt and sugar.
And I changed to eating, instead of snacking, I've been eating a lot more fruit, which is sugar.
Yeah.
And in theory, I totally get it, right? Sugar or soda to Gatorade sounds like a healthy switch. And going from, snacking on chips or whatever to fruit sounds like a healthy switch. And I guess nutritionally it sort of is, but
for
like you just don't
antioxidants
know about diet, like exactly what foods do to you when you consume them.
Right. And I think that's something that all forms of medicine are starting to kind of wake up to.
Agreed.
But again, we're fighting against a fire hose of other information. Advertisers are very much the opposite direction, right? You're hearing just eat more of this, eat more of that, drink more of this, and it's just constantly, and that's our culture. Like I grew up in the Midwest, so it's like our culture is steak and potatoes.
Yep.
Like that's what it is. The Minnesota 7-layer salad, whatever that is, where you have a layer of like mayonnaise on top of like Funyuns. There's shows that have made fun of that, which is not a real thing that in my knowledge at all.
Okay.
But that's kind of just this junk food world that we live in. Like we've lost,
and we're all so busy, right? It's so easy when you're two working parents and you have kids who are in all kinds of sports activities. It's like, well, we either eat at 4:00, which is fast food because nobody's home before that, or we're eating at 9:00 at night, between all the activities and things. So it's so much easier to microwave a dinner or make the mac and cheese or what have you, for the whole family, not just the kids, the whole family. And it's embedded into our culture, both in how we learn about food and how we are advertised about what our intake is.
Well, this has been an amazing conversation, and I feel like we could probably continue talking because we were just talking about basically the retina the whole time, which I think, honestly, the way you've set up and how you practice with that sort of model where you come in and you're basically laying a foundation and you're a coach, an advocate for them.
Yeah, we build on that every time, right? Then they like know how to read their OCTs. They're like, oh, that druise looks a little bit bigger than last time, et cetera. And again, they're involved in their own care. I do a lot of inherited retina disease too, since we have, through Foundation Fighting Blindness, we now have free genetic testing that's available.
That's huge. Is that just for you, or is that something
that is a countrywide USA program. It's through Foundation Fighting Blindness. It's called My Retina Tracker.
Okay.
So you can sign up and get it anytime. But since the advent of that, it's so easy to take care of those patients in my own office, because I would send them out to, Shea Eye Hospital, Wills Eye Hospital, solely because they would do the genetic testing. Like, well, hopefully they put you in a portal that if a study comes up in the future, they'll be able to pull you.
Sure.
But the awesome thing about this is that then Foundation Fighting Blindness stores that information, and HIPAA compliant, not with demographics, but for all of this new research that is upcoming to pull these people and reach out to them and actually give them a way to have access, if they want to clinical trials.
Because ultimately that's a huge pinnacle of the future of medical treatments.
Huge deal.
Looking at how can we genetically fix things, which is a little scary. It's like getting out into that sci-fi world.
I think the whole philosophy and the morality of it too it's just an interesting concept, and it's something we're all going to have to grapple with in the next couple of years. Right. But going back to the education point, I have a family with Best's disease, and the one girl is 8. And I looked at her at one point in one of our first or second exams with each other. I said, do you really understand what Best's disease is? We keep talking about this, but do you get it? She's like, I don't know. There's like a bubble in my retina. So I went through like how it works. I'm like, your vision is really good right now. And she had the vitelliform lesion. I'm like, but I'm concerned as it gets reabsorbed, and sort of explain that part. And the dad stopped me on the way out to the front desk. He goes, thank you for involving her in her own medical care, because I feel like every time we take my kid to most doctors, the doctor spends all the time talking to me and not to her. And the cool thing was, like, outcome was twofold. Was one, her teacher, just for fun, because she was in what's like second grade, would use like rainbow lights in her classroom, and she couldn't see when the rainbow lights were on, even though her visual acuity was fine. I was like, go tell your teacher about it. Educate her about Best's disease. And she did. And the teacher understood it a little bit. And while they use the rainbow lights for fun and play, she doesn't use them for education anymore. And then the dad came to me a few months later, and he said, you know, her talking about her Best's disease was such a huge deal for me, because I never talked about it. I didn't want to tell people that I had a visual disability. I didn't want it to affect my job status. I didn't want to affect my schooling. So I more or less have kept it a secret my whole life to acquaintances and who I'm around a lot. But I've been talking about it more, and I'm educating the public on what it is to live with some kind of inherited or visually degenerative disease process. So it's really cool how you can impact people with education.
Right. And that causes especially for a young girl like that has a ripple effect of how she will see not just you, but other doctors as she grows up and into her future. So
her older sister, I gave her all of her autofluorescence and OCT. She did a whole presentation to her class about what Best's disease is and hers and stuff. Really cool. I was so proud of her.
I have a good friend from college who I only found out a few years ago. Best's disease runs in her family. And I had to unfortunately give her that diagnosis as well. And I think it's for me, I feel it because I do know her so well. And I know she's an artist. Like, that's her trade. That's her passion. And just knowing that
right for you, because you could just say, if you didn't know her, you could say, oh, you have Best's disease, and educate them. And, you know, even though I do very good education, I have to move on with my day. I have other patients that they have a next problem that we need to solve. That person that leaves your office, their life is different from that point moving forward every day. And they will go home and say, Dr. Allen told me so-and-so, Dr. Allen told me so-and-so, you know, and spreading it out to friends, family, and educating them about it. But your name is going to come up a lot in their lifetime, hopefully in a good way.
Right, hopefully in a good way,
because it will come up either way.
Well, Amanda, this has been an amazing conversation. I really appreciate all that you're doing in our profession. You clearly have a passion. You give a damn about optometry and what you do. So thank you again for being part of the show, being on the podcast. And I can't wait to run into you again. And maybe we'll have you on again as another guest in the future.
Yeah, sounds great. Thank you so much for having me. It's awesome.